Hi everyone. Always a data session seems to be after lunch, which is when people's probably lowest energy and not that enthusiastic about data. So I'm going to try and keep this as enlightening as possible. But I will say that overall, measuring for connecting care is a challenge. And being clear around what measures are is one that we've had to think really long and hard about. I'm sure you've done that in your teams, but we're also doing that at the Commission as well. It's quite different to our other initiatives we're doing as part of the program for zero seclusion, where we have a very clear aspirational goal of eliminating seclusion in inpatient units. So today I'm going to talk about measurement, and I'm going to talk about some basics of measurement for quality improvement. Might be a recap for those of you that have been involved with the QIF or other initiatives, but just so we've all got that foundation for our next learning sessions. For those of you that didn't attend our last workshop in November, I'll just do a short recap of what we decided there about measures. And coming back to this really important question, why do we even need an outcome measure? I've heard some people ask me that, so I'm going to try and answer that question, because a lot of you I know are thinking about processes. You're thinking about transition planning, discharge planning, around quality of those plans, which are all processes, so I'm going to make that distinction with outcomes. I'm going to talk about the proposed outcome measure. Hopefully you have seen that. We circulated that a couple of months ago for your feedback. And then the last part of the session is actually how are we going to measure transitions. Sounds straightforward, but in the data it's actually not. It's not something the mental health and addiction sector has done before, to my knowledge. I know that the KPI program, for example, is a big stream of work on child and youth and a big stream on adult, but even the transition between the two is an area that we don't know much about as a sector. So I've got some proposals there on how we can do that. Okay, so measurement for quality improvement. So I think this slide is very similar to what Kevin Cleary put up this morning around these 3 questions we have. And measures really come into the second question around how we know that change is an improvement. It's fundamental. Data is fundamental for quality improvement. All your change ideas are great, but without that being complemented with data to see if that's actually leading to improvements, then this is just a change project. It's not a quality improvement project. Okay, so I'm just going to, some of the fundamentals of quality improvement is about this mindset. So this is a bit different from maybe your other use of data before for accountability reasons. In quality improvement, we talk about data as an opportunity for learning rather than that for judgment. So this is a subtle mind shift because we're not here to create league tables and rank DHBs from highest to lowest. Rather, we want all project teams to use data to learn from, rather than it turning into an exercise about performance and accountability. So with that eagerness to learn and improve, then it comes with that, it creates that mind shift to be interested and open about data. And it might show that we're not improving, but actually if you've got that openness that comes with it, it's pretty fundamental to actually stop and do things differently or change approach. So yeah, this last point, data not being used as a mechanism for control, but for learning. So I'd really like you to think about that, because it may be different to data you've been used to before, when Kevin was talking about coming in and someone saying you're not performing against this target, and this is a different use of data. So another fundamental about data for quality improvement is we talk about this family of measures. And we talk about process, balancing and outcome measures, and we need the whole family. And I'll explain what these 3 types of measures are if you're new to this. So firstly, outcome measures. What are we really trying to achieve here? So you've been thinking about that in the last session. I'm sure I've been thinking about this in the months prior as well. What is the aim here we've got for connecting care? And then, I'll give you an example for zero seclusion. Our outcome measures are our measures of seclusion. That's our percentage of people that are secluded and average time secluded and average number of seclusion events. So that's really what we're trying to do with zero seclusion. Process measures are the steps in the process to lead to that outcome. An example from zero seclusion, that's where we get your process measures from your driver diagrams. What are you changing? So it might be for zero seclusion, teams are looking at cultural processes on a mission, or use of sensory modulation, or lots of ideas like that. They are all processes to lead to that outcome. And balancing measures really complete this suite, this family of measures, because we also need to check with complex health systems that if we make changes in one part, we're not causing unintended negative consequences. And this is a really important part of measurement because we need to identify those key balancing measures to track and monitor alongside our outcome improvements to see that we're not diverting an issue from one place to another. So, for those of you that weren't there in November, or for those that were, just a bit of a recap about what we decided for measurement. So I heard from a lot of you, these were some of your ideas about what you're thinking about for connecting care. So about discharge plans being in place, the quality of your discharge plan, referral seen within 14 days, whether the GP referrals are received, declined or redirected. Also about consumer experience, crisis context post-discharge, readmission rates. These were all your ideas around measures. But however, I have colour-coded these because the green ones are actually process changes. They're process measures, whereas the blue ones are about outcomes. So I'm going to continue to keep talking about this distinction between processes and outcomes because I think it's an important one. So what we decided is that keep going as you're directing your projects on processes, and that's fine. But there needs to be that logical link to improving outcomes. You need to keep that broader outcome in the back of your mind. Actually, we're improving transition plans, the quality of those plans, because actually we're trying to make things better for consumers, or we're trying to improve their experience or reduce suboptimal transitions. So actually ensuring you've got that link between process changes and your desired outcome. And then we suggested a national aim for connecting care. So you're talking about your team's aim, and that's fine, but overarching, we've got a national aim that we're trying to make things better for mental health addiction consumers. And if we can think of this in two parts, firstly, improving the quality of service transitions. So I heard around the tables, people were talking about smooth transitions. And also to improve consumer family whānau experience of transitions. And I have these as two distinct things because I think as you measure them are quite different. And we suggested a proxy measure for measuring the quality of service transitions. This outcome could be flipping it around and viewing it in terms of suboptimal transitions. The word failed transitions is quite strong, so actually we're preferring to use that term suboptimal because it's, that's really picking up what we're doing here in terms of our proposed measure. We've also been thinking really thoughtfully at the Commission around how we're actually going to measure consumer family whānau experience nationally. It's a really important thing to do, and it is it's one that we are thinking a lot about at the moment, and we plan to make some announcements about that in the coming months about how we're going to do that. So for now, I've just put a TBC next to that, but we're definitely keeping that on the cards as this is really important to measure nationally that we are actually improving things for consumers' family whānau. And that's not just for this project, it's for every project as part of the quality improvement program. So that's what we talked about back in November. And now coming back to this point that people have asked me, actually, why are we even measuring outcomes? So I've sourced this from an NHS guide to measurement for improvement. And they make this point really nicely, I think. They say that outcome measures remain the ultimate validators of the effectiveness and quality of healthcare, but sometimes may be difficult to define and or have significant time lags. So I think that statement is definitely true for connecting care. It is difficult to define what a smooth transition is, difficult to measure, and we do have that time lag between when data is reported and when we can actually see improvement. So yes, that's true. But in saying that, it's important to have both process and outcome measures to connect your theory of change. Because if we measure processes without outcomes, you cannot be sure if outcomes have changed. So there's a saying in measurement for quality improvement about hitting the target but missing the point. So we might be, all teams, we might be doing really good jobs in terms of improving transition planning and the quality of those transition plans. But if that doesn't actually lead to improvement for consumers, then we've kind of missed the point of what we're doing here. So we've got to make sure we've got both of those two things together, process and outcome measures. So we suggested that we'll split up the measurement to be done nationally and locally, because we can't expect all teams to be measuring these outcomes. It's quite challenging things to do, and this is where the role of the Commission comes in, is to actually how can we do some of this measurement to provide that data back to you. So we've suggested back in November that locally your teams will focus on process measures, so selecting your process measures and collecting that data and reporting on it, so your discharge planning, your follow-up, your wait times, whatever the direction of your project. You'll also measure your balancing measures, the unintended negative consequences. And then we've got it there that it's optional to measure outcomes, because I know for some larger DHBs that have a lot of data capability and have that data readily available, that definitely go ahead and look at your outcomes, because you'll be able to see change faster than we can at the Commission. But in saying that, we appreciate not all teams are going to be able to measure outcomes, so we will do that nationally and then provide that data back to you, likely on a quarterly basis. So what exactly are we going to measure at the Commission in terms of outcomes? So this is just looking at that quality of service transition part. So as I mentioned, that second part around the experience of consumers, family whānau, we'll address later. We definitely haven't forgotten about it, and it's definitely a priority. So I circulated a paper a couple of months ago to the teams, and I got feedback from about 10 teams on that, which is really grateful for you for reviewing that and thinking about it, as I appreciate this is quite a complex thing to measure. And so this measure proposed that our outcome measure for measuring the quality of service transitions could be looking at within 28 days after discharge, or the date of that transition, if the consumer was referred from police back into mental health addiction services, if the referral ended due to a lack of consumer engagement or a failing in that relationship, or thirdly, whether there was an emergency department presentation that was mental health and addiction related in those 28 days. So sort of the police and the emergency department criteria is trying to pick up that unplanned entry back into secondary services. And the reason we went down this path is because we heard from you guys back in November that looking at readmission rates is not all readmissions are a bad thing. And so that can be part of a consumer's treatment plan, is to use crisis services post-discharge. So originally we thought maybe the KPI readmission rate could be an outcome measure, but hearing from you, which is why we went down this path, that not all readmissions are a bad thing. But since we've put out this proposed outcome measure from the 10 DHBs we've heard back from, 9 DHBs were reasonably comfortable with this as a measure. One DHB felt that also not all emergency department presentations were a bad thing. Not all being referred from police back into mental health addiction services is a bad thing. And yes, that's always going to be true at the individual level, but thinking about this, that we're going to be aggregated up and then monitored change over time. We're not aiming for zero. We're not aiming for no emergency department presentations. We're not aiming for no re-referrals from police. What we're aiming for is improvement over time. So that's a bit of a subtle distinction. This is what we proposed, and then we also heard back from that within our 3 connecting care transitions that actually some teams did actually like the KPI around the 28-day readmission rate and the 90-day re-referral. So I'm not suggesting that we don't include those. I'm suggesting that we could actually include all of them, and that's something that we could do from primed. We could include this police ED presentations, referral ended, and then also complement that with some of the KPI measures that already exist within the mental health and addiction sector. I'll put a bit of a question mark down there around for the youth to adult one, because there isn't actually a direct KPI that would be relevant for this. But actually I was thinking that, I'll get into this in a bit, but we actually see in the data, there aren't that many youth that actually do end up transitioning into adult services. And I'd like to talk about that with you in a minute, if that's actually what we see in the data reflects reality. But could another supplementary outcome measure be around the number of youth that transition? Because if there's confidence in that transition process, then we may expect to see the number of youth transitioning into adult services increase. And that could be a good sign. So that's just an idea. Keen for your feedback on that too. Okay, so into this part around measuring transitions. Firstly, I just would like to really acknowledge Hope McCrowan from the 3DHB. Some of you may know Hope. She's a senior data analyst and a primed coordinator for the 3DHB mental health services, and she came on a short-term secondment to the Commission to do this work with us, because it's a complex piece of work and it's one that she has a lot of expertise in. So this, when we're trying to think about all the transitions that exist within the mental health and addiction sector, there are many, many transitions. So I appreciate this might be quite small at the back there, but we've got inpatient services down the bottom, and we see that transition between youth inpatient into adult, into older persons. We see transitions into community services between youth teams, adult teams, crisis resolution services, older persons, the involvement of NGOs as well, and then also, of course, the GP and primary being at the top of all of that. And the purpose of this illustration is just to show you that there are many, many transitions that exist within mental health and addiction services. And this diagram excludes specialty services. This is excluding forensics and intellectual disability, eating disorder services. But even with those exclusions, there are still many. So what we're doing here is we've only selected 3. But those 3 are part of a broader sector of many transitions. We know that service transitions in the sector are multiple and there are potential risks to consumers and their family whānaus. And we know that some serious adverse events have been linked to a failed service transition. So when we were measuring, we need to be actually clear, what is a transition? I mean, I know that probably sounds obvious to you, but actually it wasn't really to us. So the definition that we have proposed for measurement is it's a transfer of care between services. So it could be an internal transfer, such as between a DHB inpatient team and a community team, or an external transfer between being referred onto another organisation, such as primary care. And this definition, this transfer of care definition, it's talking about sort of a transfer of responsibility for that consumer. And it's different to another definition that might exist in the sector around a transition being a transfer of information. And that's different to a transfer of care or transfer of responsibility. So for the purposes of measurement, we've defined a transition as that transfer of care. So we might see service A, that could be an inpatient service, that is transitioning onto service B, which could be a DHB community service. And there could be a small overlap between that inpatient and community service, but that transition between service A and service B takes part. Or service B could be your GP, and then they're transitioned into a service A. And the GP is dotted. They have some involvement in that time, but the transfer of care has taken place into service A and then back again to service B. So we're talking about that transfer of care here. And then of that maze of many transitions within the mental health and addiction sector, this diagram is to illustrate the 3 that we've selected as part of connecting care. So we've got the transition from adult mental health inpatient units into the adult community teams, the transition from youth community to adult community, and then the transition from community into the GP primary mental health care. So you might note that we haven't put NGOs on this diagram, and I'll explain why. So what we found in the data is that there are very few consumers in New Zealand that actually there's not that transfer of care onto NGO services. Instead, what we see is concurrent services being provided by the NGO alongside DHB community services mainly. And so while there hasn't been that transfer of care onto an NGO, within these 3 transitions, obviously NGO involvement is really important. So we're suggesting that within these 3 transitions, we can look at NGO involvement simultaneously within these transitions, rather than it being that transfer of care as such. So this means, for example, we'll be able to report for the consumers transitioning from inpatient into a community team, what percentage also had NGO involvement at the time of that transition. And then we can compare outcomes for those consumers with NGOs involvement and those that didn't. So NGOs are definitely part of the piece of work we're doing here, but it doesn't meet that definition of transfer of care. Okay, so we are proposing nationally, we have the primed data set, which is extracted from the Ministry of Health to us at the Commission, and we get quarterly extracts of that. What we do know is that primed currently is not set up to capture transitions well. However, it's a national data set that is available to be used, and what the work Hope and I have done is try to come up with the best possible definitions we can with what's currently in primed. So the data approximations may differ to what is a best practice definition. In the process of this work, we have come up with a number of recommendations to the Ministry of Health on how primed can be improved, and Hope and I are going to be presenting that work in June at the Primed Site Coordinators meeting, because we think that primed could be substantially improved to capture transitions better, but currently it's limited. So what we're proposing here is the best that we can do, and we think they're pretty good definitions with the data available, but we're really keen for your feedback on that as well. So, I know you're not going to read the detail of this, but I'm just putting this slide up here to illustrate that this is what the data definition looks like for the first one about inpatient services onto adult community services. It's using the primed team setting codes, the team type codes, looking at the referral to codes. For those of you familiar with primed, this might make sense. For those of you who've never seen primed, this will probably look like a foreign language. But what I have is back there, we'll give you a handout, every project team give you a handout, and we ask you to take these data definitions back to your DHBs, share them with your prime site coordinators or your data colleagues, and give us feedback on what you think about these definitions. We've given a confidence rating based on our investigations in the data and the data quality issues that are known and primed. And we think this is the best one, this inpatient services to adult community services is the best one that can be measured currently and primed. So we've given it a high confidence rating. This next one around DHB community services to primary care, we've given it a medium confidence rating, and it really relies on this referral to code GP. But that's why I was really interested, David, this morning when you were saying that actually being referred to a GP doesn't necessarily mean a transition's taken place, which is problematic for this, measuring this, because we don't have nationally primary care data. We don't know if people are going to see their GP for mental health or addiction-related reasons. And so we're really relying on that referral to a GP and assuming that a transition's taken place, but it might not. So locally, I assume you've managed to link up your primary care data, and so that's another example where local data is much more advantageous than what we can do nationally. So we've given this one a medium confidence rating. And the third one, unfortunately, the youth to adult is the hardest of them all, and we've given that a low confidence rating. And that's not to say that in measurement for quality improvement, it doesn't have to be perfect to be useful. What we're trying to do is we know that there are data quality concerns, but with the current limitations, is it still good enough to provide some indication? And that's a question for you, and we've asked you, when you take these data definitions away, to feed that back to us. Given what we've got, we're trying to use existing data. We're not trying to create a new massive data collection and turn this piece of work into data collection. We're trying to use existing data and really keep it focused on changes and improvement. But what we've got, is it good enough to provide that insight into changing outcomes? Because we're going to overlay these three transition definitions with that outcome measure to see against these three transitions, are things actually improving over time? So after this, I'll hand out those data definitions and to take away back to your teams. But just to show you some indicative numbers that we got using these definitions. So we find that nationally, in primed, this is what primed tells us based on those data definitions for the 2017 calendar year. It sounds a bit old now, but in the next week we're going to get final data up to 31st of December 2018, so we're just missing a few months at the back of 2018, so hence why I'm reporting currently 2017. That there were almost 11,000 adult mental health inpatient transitions. 90% of them went into a DHB community team. And within those 9,729 transitions into an adult community team, we found that 37% of them were receiving NGO services at the time of discharge. So this shows you that NGO involvement is significant, like 37% is a significant number. We found that there were 665 transitions between youth to adult community teams, and then 19% of those were receiving NGO involvement, NGO services at the time of discharge. But as mentioned, we think this number is on the low side and think that there are more transitions from youth to adult services, but there are data quality issues there. And then from DHB community services back to GP primary mental health, we found that there was just over 11,000 transitions nationally. And then 12% of these transitions were also receiving NGO services at the time of transition. So in the paper that I'm giving you, I've broken this down by DHB and by ethnicity. So you can see for your DHB, do the numbers make sense? And we have found that some of the numbers look good for some DHBs, and working with Hope, we've managed to align them to what the three DHB numbers should be. But we know that actually some DHBs don't look quite right. So, for example, DHB community to GP primary care relies on that referral to code and prime being GP. But we find that not all DHBs use that code correctly, and a lot of teams are using NRs or SRs, other codes. And so as part of this work, we'd like to improve the quality of that data as well. So when I give this out, we ask you to take it back to your DHB, talk to your data colleagues, and then let us know about whether these data definitions are suitable to monitor outcome measures, appreciating that there are these data limitations in primed. And then if you don't agree, then come up with another idea on how to do it. As I mentioned, it is not perfect, but I still think that these definitions will still be useful to monitor outcomes. Finding that right balance between perfection and usefulness. So next steps. So learning session 2 is coming up in August. And so we've got a number of Zoom tutorials. One will be on run charts. So those of you that have been involved with zero seclusion, you probably won't need to come to that because you'll understand run charts. But those of you that haven't, we'll run a Zoom tutorial and we can talk about the fundamentals of run charts. Run charts are a way to plot your data over time to see if you actually have an improvement. We also have, what's not listed up there, is there's a Zoom tutorial on data collection coaching on the 12th of June. And that we can go through your data collection plan, talking about how you can start collecting some data. Because as Kevin mentioned this morning, let's use this opportunity to collect some baseline data. So before we rush ahead, collecting that baseline to actually then be able to compare changes against. So give us your feedback on the transition definitions, and then start selecting what your process and balancing measures are. Some teams might have already done this, and I know a number have, but if you haven't, start thinking about what these measures are, and one of those Zoom tutorials will give you a bit of coaching around what some good measures might look like. And then we will, at the Commission, once we've got your feedback on these transitions, we'll start reporting back to you the baseline outcome measures. And then learning session 3 is in December 2019, so we'll have further content there.